Bismillahirrahmanirrahim. Today's lecture is one of those lectures which are intended for medical students as they are rotating through neurology so they can understand how to get a good history for peripheral nerve disorders. And as I'm a neuromuscular subspecialist, so I try to give you some of my own perspective as well. So whenever you take a history, the scheme more or less remains the same, but we have to modify based on our pathology, what the presenting complaint is, and then accordingly we will ask more directed questions during the later part of the history. When it comes to peripheral neuropathology or for peripheral neuropathy patients, there are more than 200 different causes or etiologies for peripheral neuropathy. But the most important thing what we need to understand in the start of the history, as the patient starts giving us detail, besides knowing the age and the gender of the patient, is patient having positive symptoms or negative symptoms. So positive sensory and positive motor symptoms. For positive sensory symptoms, there could be hyperesthesia, there could be burning, lancinating pain, or tingling, pricking sensation. That is more common positive sensory symptoms. For positive motor symptoms, patient may complain about twitches here and there, especially in lower extremities if it's a length-dependent pattern. And then there could be cramps beside twitches. When it comes to the negative sensory symptoms, which is usually loss of function of the nerve. So in that case, there may be loss of sensation most of the time in these patients. When we talk about the negative motor symptoms, there will be fatigue, there would be weakness, and those are the most common symptoms that we come across. So that gives us the idea, could it be acquired peripheral neuropathy or genetic peripheral neuropathy? So understanding the concept of positive and negative symptoms is very helpful in the outpatient clinical setting. Next comes the same scheme of what we usually do in our patients in any medical disorder, which is history of present illness. So whenever we try to take the history of present illness, we need to understand the chronology of the disease. So first of all, when did it started? How it's progressing? Is it fast? Is it static? Or is it slowly progressive? So those two things really helpful in any neurological disorder, especially in peripheral neuropathy. So onset of the disease, the progression of the disease, and then we're going to get to the associated symptoms. In patients with peripheral neuropathy, besides we're going to ask them about the sensory symptoms, motor symptoms, we also have to ask them about the activities of daily living which are affected because of this. Because most of the time patients don't mention pricking sensation or loss of sensation unless there is a weakness, which is a more common symptom. They usually tell you that the shoe or the slipper slips out of their feet, or they trip more in the night, which is usually sensory related phenomena or sensory ataxia in these patients. Additionally, these patients may complain other symptoms which we have to pay a focus to, especially as they're going upstairs or downstairs. I usually ask this question because it gives me the idea if patient is complaining difficulty going upstairs, it's usually proximal weakness, which could be part of peripheral neuropathy, especially if it comes to CIDP, but it is more commonly seen in muscle disorder. Additionally, patient may complain about difficulty going downstairs early on, which is what we commonly see in a length-dependent peripheral neuropathy. Additionally, we can ask these patients about dizziness on standing, or in the review of symptoms, or difficulty or constipation, or diarrhea alternating with constipation. Knowing in these patients what other medical problems they have is very important, especially diabetes. Even if it's a pre-diabetic patient, they may still have peripheral neuropathy symptoms which may not be obvious otherwise. Family history is very important in peripheral neuropathy, especially if we are suspecting genetic peripheral neuropathy. Knowing if there is any family member who has neuropathy early in the life would be very helpful. Additionally, we can ask about the social history, how it's affecting their quality of life, and how they cope with that, what we can do to make them feel better other than treatments is very helpful. Medication and toxin exposure. If there is a any toxin or medication exposure before the start of symptoms is very helpful. There could be antibiotics, there could be heavy metals, which can cause peripheral neuropathy. It could be motor, it could be sensory, or it could be a mixed peripheral neuropathy having both sensory and motor component. Also, understanding the concept of motor, sensory, and autonomic nerves is very helpful. If we go in a stepwise manner, it would be very helpful to organize the history. What I do, I try to do a paragraph for motor symptoms and sensory symptoms and autonomic symptoms. At the same time, I do ask the patient about the bulbar or the respiratory breathing issues with this peripheral neuropathy. If there is any swallowing issue, there is any vision issue as part of the review of symptoms. That also gives me the idea that if this peripheral neuropathy is only limited to the peripheral nerves, or there could be bulbar involvement, or there could be a syndrome which is causing peripheral neuropathy as one of its manifestations, especially when it comes to mitochondrial disorders. Once we have got a detailed history, and then we're gonna get to the examination. In examination, especially in peripheral neuropathy, we try to focus on what's the pattern of weakness? Is it a proximal more weakness, or a distal more weakness, or is it kind of diffuse weakness, peripherally and proximally? That would be really helpful, especially talking about CIDP, AIDP. There could be proximal as well as distal weakness at the same time, which is part of the clinical criteria. But documenting that, if a patient comes later on during the disease, this should be a directed question, trying to understand what was the initial pattern of the disease, despite the fact they came back to you after a year or two of their start of symptoms. Then there is any associated sensory loss or not. It becomes a little bit of tricky when you try to see a patient who is having predominant motor symptoms, there are no sensory symptoms, and you're trying to see, is it a peripheral neuropathy which is only involving motor nerves, or there is a myopathy in this particular patient. In that case, sensory loss could be very helpful to differentiate between the two. Then comes associated features. There could be hearing loss, there could be vision issues, there could be bulbar symptoms, there could be other organ involvement, there could be organomegaly, especially talking about Poem syndrome, or there could be optic atrophy, there could be retinitis pigmentosa, especially talking about the mitochondrial disorders. As I said, there are more than 200 different causes of peripheral neuropathy, so trying to get a detailed history is the key to cut down on our investigations, which we're going to discuss in some of the lectures. What should be the chronology, or what should be the list of investigations we can do step by step in these patients, unless there is an emergency where you can do a lot of investigations at the same time to save your time. So try to understand the concept of history, examination, and then try to get to your differential diagnosis, and then doing targeted investigations not only save time as well as money for the patient. I really hope this lecture would be helpful for the medical students who are rotating through the neurology outpatient, or who are rounding on the inpatient service. Thank you very much.